to diabetes. He had a family history of coronary disease and presenting as a chronic stable angina of crescendo nature, and he had inducible ischemia and GMT, and angiogram is showing a proximal to mid-segment LED critical calcific lesion. Of course, it is not a complex itself can pose some difficulties in the passage of the balloons and stents. So this is a CT angiogram which is demonstrating classically type 3 LAD with a tram track calcium almost near osteoproximal segment to the extending up to the mid segment. So we can observe that one, and that indicating classical heavy calcification on CT angio. And the procedure planning is a good block modification by means of a device like IVL balloon, which is C2, and followed by LAD stenting. The approach is the right radial motion. And this is the angiogram. You can see that almost osteoproximal till the mid segment of LAD, that is its proximal segment is basically before diagonal origin. It is a tram track calcium, you can observe. It is a hazy lesion in caudal views and tight lesion in cranial views, indicating eccentric and calcific lesion showing a tram track appearance. And this is the procedure details. And we did the pre-dilatation of LAD as a part of lesion preparation, facilitating the strategy is IVL balloon, which is a bulky balloon. First, you have to prepare the lesion for facilitating the IVL passage and navigation. 2 to 10 millimeters semi-component balloon at 12 atmospheres. After preparation of the lesion, then we did you can appreciate the type of the calcium tram track and stent boost, which is one of the cost-effective intravascular ultrasound. So we took the 3 to 12 millimeter shockwave C2 IVL, and systematically we delivered almost 4 cycles, and the lesion is very nicely with 4 cycles, 40 pulses were delivered. How the calcium becomes, you can observe the severity of the calcium. And then once after preparation, then we put the 3 to 21 millimeters SR summit DES deployed at 11 atmospheres. You can observe how in stent boost also the expansion is very good actually, and you can appreciate actually with the stent boost the expansion. And then subsequently in calcific lesion, the most important is malpositions you cannot observe unless you do the intravascular imaging. Here already we did the stenting and all these expansion and stent boost. We did a systematic post and dilatation to prevent malpositions with 3 to 12 millimeters balloon, almost to non-compliant balloon with up to 18 and 20 atmospheres. This is the final result. You can appreciate. You can appreciate well expanded and well opposed stent, and with excellent ME3 flow, and patient were discharged in hemodynamically stable condition and an appropriate medication, that is a secondary preventive drugs. Of course, this doesn't come under a complex calcific lesion. It is a simple calcific stage segment, non-tortuous. More of tram track calcium rather than a protruding calcium, where it is a balloon crossable lesion. So once there is a balloon crossable lesion and heavy calcium, both by means of CT angiogram as well as fluoro, we did the systematic preparation by means of routine balloon to facilitate IVL, which is an aggressive calcific modification tool which causes redistribution by microfractures with ultimately good stent expansion opposition, and with post and dilatation with a very good result to prevent the both acute and long-term stent patency rates, preventing the stent break.
Thank you very much, for your wonderful case presentation. It is algorithmically, it is a very classic case.
Yes.
It's a tram track calcification and balloon crossable lesions. So it is perhaps in these cases, IVL is the only, standard therapy for lesion preparation. And at the same time, once we have seen that it is the only device, that perhaps the IVL is the only device which can cause the plaque modification in such a way that even at lower pressure the stents open nicely, and not much of post dilatation is required in most of the cases. So it's a wonderful case. So I would the case is open for discussion. I have to ask Dr. Nikhil to comment on this case and have any opinion about it.
No, I think I agree with you entirely. I think this was an excellent presentation of a good case done with an IVL, and also highlights the importance of judging the calcium before the procedure, and going ahead and aiming for a good plaque modification before stent deployment. And so I think it's a good case. It's not a very long lesion, balloon crossable, straight segment, and I think a very good case for an IVL. And you see how easily with a which was highlighted again by the is that the stent expands so nicely, and one did not require any major high pressure dilatations to expand the stent. That means the calcium has been modified adequately.
And some questions to Dr. Sonande and Dr. Nikhil.
Sorry?
So actually, suppose this is a simple calcific lesion. Supposing having had a complex calcific lesion modified by means of atherectomy and this IVL, and what is your preferred stent choice in calcific lesions after adequate plaque modification?
I really do not have any major stent choice. I think plaque modification is more important than the stent choice, I would say.
Yeah, that's it.
So if I see calcium, we've grown up in the time of rotablation, and if it was for rotablation, I would have gone in this case with probably a 1.75 burr right to start with. And we've been actually doing even radial interventions. I've in fact recently used as 1.75 burr using a radial intervention. So we have good hardware available now, so we can do that. But here, like you said, we have a very straight segment, balloon expandable. The problem happens when it's a very tight lesion. It's one of those 90-95% lesions, long segment lesions where you have, difficulty in passing very small balloons. In that case, one would prefer a rotablation in this case. But I think this was a very good case presentation for a IVL post-stent.
Another very important point, which is a pointer maybe for the future, that is, I would ask, whether the CT angio has got a correlation with the angiographic calcification, and in some cases, if it's a very heavy calcification in CT angio, this could be a pointer that the plaque modification would be necessary in the form of rotatripsy. Either a rotablation is necessary, or on top of that something is necessary like IVL. So CT angio could be a pointer. It is a very nice finding what he presented, that he could correlate that. Yes.
Can I have we important really use CT angiogram as a routine before such patients. In fact, possibly if this patient had gone in for a CT angiogram, looking at the amount of calcium, one would have said very high calcium score, okay, we're not going to do a CT angiogram. But
people say that if it is more than 1000 angstrom, so CT might not be very helpful. But in such your cases, a good CT image could correlate with plaque modification, heavy plaque modification in the form of IVL or something, and that could be a good pointer.
Sure, and I think one should have a very low a threshold for using a plaque modification if one sees visible calcium? Of course, you have guidelines on looking at calcium through looking at an IVUS thing, or looking at the an OCT or whatever to see circumferential calcium or the arc of calcium. But I mean, I've seen cases where the operator has decided on not to do a plaque modification because the calcium was did not indicate, it was not, the amount of calcium did not indicate a plaque modification, and then the operators got stuck. So
That's quite.
it's not uncommon.
This is quite a horrible situation. Yeah. And in another case, in the most of the cases, if it is a very severe calcium, your IVUS catheter and OCT catheter will not go. In such cases, perhaps if you do have CT angio, perhaps it would give a good correlation that whether something is necessary. So with that, I think Nikhil, you can call for the second case, and we should give a good applause to Dr.
Yeah. Thank you.
So let me just get the
next presentation is by Dr. Parin.
Hi, am I audible and visible?
Yes, sir.
Both.
Hi, good evening, one and all. So I'll be talking about a case which looked very simple, but had a lot of difficulty in doing this case. It's a case of OCT guided device selection for a patient with instant restenosis. So this is a patient who had undergone angioplasty to RCA in 2018 elsewhere, and he presented with chronic stable angina, and this is the shoot in front of us. The left system looks fairly okay, and we can see the previous stent. It has a tight discrete severe stenosis, as we can see in this image. So patient has presented with the chronic stable angina and a tight 90-95% ISR focal lesion in the stent. So looks very simple to begin with, and I thought it will be like a cakewalk, a type A, probably a lesion for me to do it, but that was not the case. So I started normally this case by passing the wire using a balloon, but my 2 millimeter balloon wouldn't go in, and after that I decreased the size of the balloon to 1.5, 1.2, and none of the balloons went into, so it became a balloon not crossable lesion for me, and it's that time when I decided that yes, this case is going to give some trouble. So I took a rotablator. We took the consent of the patient on table, inserted a temporary pacemaker, and then I went ahead with a rotablator, and that is with a 1.5 millimeter burr. So post rota, this is the first OCT run which I got. This is what it is. So we can very clearly see here that the calcium, that the blob of the fibrocalcific lesion is still present in this area, as we can see now as the image is moving. And yeah, as we come here, we can see quite clearly. So I have still images to make this more clear. So this is the distal segment of the OCT, this is the proximal segment, and this is the calcium blob, which has still not given way with a 1.5 millimeter rota burr. And as we can see in the OCT, this is the tightest portion, and this is the under expanded stent strut, which I could clearly see in the OCT image from the previous case. So going down further, I decided to upgrade my rotablator to 1.75 millimeter burr, and this is the image which I got after the 1.75 millimeter burr post rota ablation. So as we can see, even after a 1.75 millimeter rota ablation, this calcium block has still not given way, and we can see it very clearly. Though the tightest point has somewhat given way, but still, if I would see imaging wise, OCT wise, there is a blob which still persists at the distal edge as seen on the OCT image. So I took a cutting balloon and I went at 12 atmospheres. The cutting balloon size was 3.5 into 10 millimeters. And after using a cutting balloon, the result looks reasonably okay. So this is the post cutting balloon OCT run which I have taken. As we have time constraint, I'll directly go to the image of the OCT post cutting balloon. This is the distal edge and coming to the proximal. So it was a fairly expanded lumen which I obtained after the cutting balloon post 1.75 rota ablator. After getting into that, I used a 3.5 into 18 Vivo ISAR stent which was deployed at nominal pressures, and it was optimized with the NC balloon of 3.75 into 12 millimeter NC balloon, which I went at around 14 atmospheres. So angiographically, this looks like quite a good result. But yes, I did confirm it by doing an imaging again. As we can see, angiographically, this looks quite okay. This is the final run which I got after optimizing my stent. I think I achieved almost a 95% expansion with well expanded, well opposed stent struts with no much of under expansion. So what did I learn from this case? So in presence of severe hard calcification, manipulating the OCT catheter may damage it. As Dr. Ray sir just mentioned it in the previous case, I directly went in actually with the OCT catheter, but it did not go and it broke. So I had to take another OCT catheter. I have not shown that image because it's not recorded, but it did happen with me in this case. And with view of OCT documented fibrocalcific restenosis and under expansion, rota ablator was performed. And also because of inadequate result post rota ablation, a cutting balloon was used. And with OCT, it helped me to optimize the stent quite well. So the learning is that imaging is of utmost importance during PCI whenever possible, if financial issues are not a problem. And that makes life a little bit easier in counseling and doing the case. Thank you everyone for your patient listening.
Shall we go ahead with the next presentation?
No. It's a interesting case.
Little bit discussion is needed. It's a very interesting case.
Very interesting case.
For discussion.
It's a very interesting case as well. It's well done, and Parin is a young man with a lot of courage and everything, and he has done the case so nicely. But I think I would point 2-3 things. After that, it is it is open for discussion. There is one thing which we learned from the OCT and imaging, that the calcium nodules happen at the bend. When there is if the artery is bent, at the area of bending, there the calcium nodules develop. And this gentleman had a calcium nodule just at the bend, and that's why his image is so beautiful. And he showed the image that there is a calcium nodule at the bend of the, at the area where there was a restenosis. And now calcium nodule is best treated by IVL. So he did the right thing to, rotablate to make a passage of the thing. And he took a 1.75 bar. Luckily, his guide wire bias is such that the 1.75 bar cut the calcium nodule. Otherwise, a IVL balloon would have been a better choice. So it is a small thing which I can add. And after that, it is open for discussion.
Sir, my question here is that once the patient has undergone angioplasty, patient has a ISR and he has a calcium nodule, as sir you have clearly pointed out. Now we have, obviously we don't have using orbital atherectomy, though it is there in India, but it's not easily done and available everywhere. Is IVL a class 1 indication in these cases, or we are using IVL just as a out of indication in these types of cases? So can we use actually IVL in such cases?
No, the point is you cannot use orbital atherectomy inside the stent.
Yeah, correct.
So it's a contraindication. So you have done the right thing to use a rotablator. It's a class 1 indication. And after rotablation, perhaps in calcium nodule, the best treatment is by IVL. And now there is no head-to-head comparison between the the atherectomy device and IVL. But so far, the knowledge is acquired that IVL is better choice than any of the atherectomy device in calcium nodule.
As Dr. Parin, I can have two important comments. I have bulk experience of ISRs.
Yes.
Here, in this case, actually, two important things you should remember. The first and foremost is it is a protruding nodule. And if it is a wire bias is there, the rotablation is the best one to ablate or reduce the volume of the nodule. Anyway, orbital is contraindicated. And in this case, actually, my approach, but anyway, you had very good results. But again, recurrence chance is very, very, very high. After 6 months, again the patient with the chronic stable angina, again the nodule at the same place. I have experience, I have worst cases, 3 cases like this. And again, put it into the inside the stent again. He will present with the angina. After 1 year, you see this case follow closely. And in this case, actually, the best approach is, as you told, rota, careful rota, especially when you are doing in a ISR lesion, followed by aggressive block modifying device like IVL, Dr. So on and day, because it will produce both microfractures along with the macrofractures, and then after ablating the volume, it is a react like it reduce the volume and modify the block, especially when the calcium nodule is there. And IVL is the best aggressive calcium modifying tool compared to other tools, and followed by OPN. Very, very important. Once you fracture the nodule by OPN, you can just, especially ISR protein nodules, you reduce the volume, you modify the aggressive device, and OPN, just you can press it, and then followed by DEP. Sometimes because once you increase the 2 layers, the acute result may be good, but long-term results, again protruding nodule, 2 layer is a negative for the recurrences of the ISR. Actually, in this given case, especially the calcium nodule is the OCT finding. This is my say, because we have seen this type of cases, plenty of cases actually, again recurrences. That's why even Dr. Akasaka and Dr. Gary Minji told, very, very difficult, despite these type of calcific nodules presenting as a chronic stable syndrome, unlike ACS, which is a soft nodule and which is a compressible and less type of recurrence compared to this one. So naturally you do not know, but this is the approach, this alternative approach. But anyway, you got very best good result in this given case.
So shall we move ahead to the next presentation? Move to the next presentation. So next presentation is by Dr. Dixit Garg, Manipal Hospital, Gurgaon.
Can you? I would request you to shift my presentation to the next case because I've just logged it. I've just reached home and I'm opening up my presentation. So if you can go ahead and
Sure.
just give
Sure,
me.
sir. Sure, sir. Sure, sir. Dr. Jena, can we start with your presentation, sir, then?
Thank you. Thanks to all the chairpersons and moderators.
So your voice is not audible.
Is it audible now?
So a little bit it's audible.
Camera sir, you have to be audible.
Now can you hear me now? No. No.
A little bit is audible.
No. Let me just give me 1 minute. Is it okay now? No.
So you can try removing your headphones. Just remove your headphones and
Can you hear me now?
So we can't hear you properly. A little bit is audible, not completely.
Just let me change my audio device.
Sure, sir. Sure.
How is the voice now?
So we can hear you now.
Now you are audible. Camera sir.
Yeah, so some problem with the microphone probably. Thank you, sir. So let me just share my presentation. And it is about PCI in lesion with high calcium content and how polymer-free stents have made life a little easier for us. So we have a 58-year-old male. He has a case of suprasellar tumor. He had a couple of comorbidities. His LVEF was 38%. He was diabetic on insulin. He had hypothyroidism, hypertension. So a lot of comorbidities. Basically morbid obesity, severe OSA, and LV dysfunction. This is the MRI of the brain showing the suprasellar tumor. Basically, he was being evaluated for the suprasellar tumor, and at that time, his cardiac findings were there. So this is the angiogram that was done because the patient was found to have LV dysfunction. So very bad looking calcium here, diffusely calcified, heavily calcified coronaries. So right coronary artery, typically it is a very high calcium content and it is a tortuous. Almost it is like an U-turn here, 180-degree tortuosity in the mid part of the RCA and causing some 95% or more, 95% or more stenosis in the RCA. Then, so I mean, this is the part I am talking about. The heavily calcified and 180-degree bend in this tightest part of the RCA, and the calcium extends right up to the distal RCA. And as far as the left system is concerned, LCX is okay, but there is again another calcified 99% stenosis in the LAD. And also there is a diffuse disease that is heavily calcified. So, I mean, for such cases, surgery is definitely the best option with this degree of calcification, with this degree of diffuse disease. However, no surgeon would touch this patient with severe OSA, morbid obesity, suprasellar tumor, and a lot of other comorbidities. So after discussion, finally, we decided that we will go ahead with a PTC. But how to do PCI in this case with this degree of calcification? So our guiding catheter was an AL2, and because AL2, we need good guiding support for such type of cases. So AL2 is the guiding catheter, and even with a floppy wire, it was not possible to cross this lesion. So this crossing also took some 20 minutes to more than 20 minutes, and finally we took a Fielder XTR, and Fielder XTR could cross. In this case, as we know that even a small balloon will not pass. So my plan was to do a upfront rota ablation, and we took a Corsair microcatheter because Corsair has this unique torqueability, and that helps in passing this microcatheter. And we could pass the Corsair across the lesion, and then over the Corsair we took the rota wire. So this is the algorithm, the Di Maria algorithm. And if this lesion is not balloon crossable, then we take rotational atherectomy. If it is balloon crossable, then go for an imaging and further debulking or plaque modification depending on the imaging findings. But here in this case, it was balloon uncrossable, so we took rotational atherectomy up front. It was a 1.5 bar, and it took some time. It took a few passes for the rota to cross, and the bar speed was around 170. Normally I do between 165 to 185 like that. Then finally, after some 2.5 minutes of rota, we could cross, and we gave a polishing run. And we got some lumen after rota. So this was all hard calcium. So rota ablated a part of the calcium. So there's the new concept of volume reduction. We've achieved some volume reduction in terms of the lesion. And post rota, we did NC balloon dilatation just to make sure that there are no protruding spicules, and there is that reduces the risk of IVL rupture. Then we did the imaging. As expected, it was thick 360 degree calcium. These are the tightest portion of the lesion. And in some areas, there is loss of reverberation, there is thick calcium. So this is expected. And it is difficult to make assessment about the vessel size here. And these are some of the heavily calcified areas. Then we did IVL, 3.5 IVL could cross after pre-dilatation with 3 NC balloon. And in this lesion, the tightest portion, we delivered some 40 or 50 pulses because we wanted to do the LAD also. And after IVL, as you can see that the west is broken off, and there is some good luminal gain. Post IVL, we took OPN-NC, and with OPN-NC, we did good, again, high pressure pre-dilatation. So the lesion was prepared. Then we took a 3.5 into 48 SR summit, and the stent actually crossed. The guiding support with AL2 helped, and in this case we also used a guide catheter extension because this part of this bend needed some extra support for the stent to cross. However, after stenting, we can see that the stent is well expanded, and post dilatation was done with a 3.44 NC balloon. And this is the final result on the RCA. So, this is one of the, this took a very long time to do because of the extent of calcification, the very complex anatomy with tortuosity, and basically the calcium is the lesion content of calcium is so high that the lesion Sorry, I think I lost my presentation in between.
Yeah. Phenomenal, Jena sir. Hats off to you.
Thank you, sir.
Exactly.
So,
It's a bend calcium,
sir,
napping calcium, both uncrossable, undilatable, correct gadgets at the correct time.
sir,
It's a very good, perfect end result.
thank you, sir.
Whatever the steps in algorithms, uncrossable, good guide support, and it is once it is a microcatheter uncrossable is a very classical example, and then followed by rota, and rota should be very careful, especially bent calcium, because it is a outer side calcium is more, it is a wire bias, okay, then it modified calcium very well. Once it becomes crossable, then undilatable lesion which you have to face, and that also you phenomenally by IVL. The only thing which I have seen at this juncture, OPN is slightly risky as you are going more than 30-35. Because IVL is a safety fracture modification it will do. At low atmospheres, the acoustic waves will create 50 atmospheres acoustic waves. So that effectively the microfractures and undilatable becomes dilatable. Once after that one still residual is there, which you tackle with OPN. So that the unexpanded, still residual unexpanded stent, you expanded very well. So that phenomenal, this is a real complex calcific lesion, and you selected the appropriate gadgets with very good results.
Thank you,
Very
sir.
nice, actually, phenomenal.
Sir.
Hats off to Dr. Jena sir.
Thank you, sir.
Thank you, Anupam, for your wonderful presentation. But I have a few things to say. One of them is the guide wire bias, which helped you as you have taken an M+. When you take an M+ in a RCA, the guide wire is towards the inner side of the curve.
Sir.
And if you take a RCA, then the guide wire bias is towards the outer side of the curve.
Yes,
so,
sir.
as because you took an M+ catheter, the guide wire bias is towards the inner side of the curve, and that helped your rotational activity.
Sir.
But what was the size of IVL you took?
3.5, sir.
I would have taken a 4 millimeter because your artery is really large.
Yes,
that's
sir.
why after IVL you needed a OPN balloon to prepare.
Sir.
Otherwise, it would have opened it very nicely.
Sir.
So I thought the IVL would have been 4 millimeter, and it is a wonderful case, as Dr. Kapardhi has said. It is a wonderful case and it's a complex case. Congratulations to you. And I would ask Dr. Nikhil to say a few words about it, so that. I think he lost his contact. So with that, can we go to the next case? Yeah.
Oh, sir, we can do that.
Okay.
Doctor, thank you, sir. Dr. Dixit, can we
I have a
start?
question, actually.
Yes, sir.
Just a question. Actually, this OPN-NC which we are using as a high pressure gadget for pre-dilatation, are we okay to be used it for post-dilatation also? Because I have read it that it will fracture the stent struts if we use as a post-dilatation tool, and it should be only used as for pre-dilatation. So any views on that?
No, Dr. Parin, actually you are mistaken. Actually, I have bulk experience with OPN. Even for post-stent dilatation, is a very good balloon, because even after adequate size IVL balloons we have seen still some unexpanded portions of the stent. Especially, that's why I asked that question first case when I presented. What is your selection of the stent? Yes, the stent with the high radial strength you have to take. Very important. Calcific lesions, especially Dr. Jena sir, just I want to tell this one. If that type of calcium is there, my choice of stent is totally different. Sorry to say, because high radial strength is needed where 81 to 83 micron stent is more important than 68 micron stent. Remember, or 78 micron stent. Very good with connectors. That is another important. Not the open cell design stent. It is a connectors design which, along with the which should very good radial strength, especially when you are that type of calcific bend lesions. Once after adequate modification, unlike my case, which is a simple calcific lesion, here high radial strength stent is needed. And OPN, even I have bulk experience of an expansion even after IVL. We did with OPN with perfect result. With the stent boost as well as intravascular imaging, we have documented cases are there. So that's why you can use post this one as well as pre also. You can use this OPN bill.
No, the point is, why should OPN balloon be used in all cases? No. OPN balloon is a balloon which should be used in the time of duress. Particularly this is more important not before pre-dilatation. I think it is more important in the post-dilatation. After plaque modification, when you see that your stent is not apposed totally, what you do? You have only two options. Either you have a OPN balloon. If it does not work, you have to use a IVL balloon. So, in many cases, you will see that after doing a rotational atherectomy or after using an IVL balloon, still you could not judge that the stent apposition will not be proper. It becomes sometimes, it is very practical to see that after a good plaque modification, again, you see that your stent has not been apposed nicely. So there, you have only one option, that is OPN balloon. And I have used OPN balloon in lot many cases. And really it is helpful. Don't be afraid of using an OPN balloon because it does not increase in volume. The most important thing when you do a post-dilatation is if your balloon increases in volume, there is a chance of rupture. That is the dangerous thing, And once there is a rupture inside a stent, it is always a class 3 rupture, and it is horrific. So basically, it is better to use an OPN balloon rather than is 1:1. You just make it 1:1, and believe me, even after 40 atmosphere, it doesn't increase in volume.
That is more important, Dr. Sonde aptly told. The OPN balloon, when we are increasing about 35, with each 1 atmosphere increase, I keep the covered stent ready.
Yeah, that's it.
That is more important.
I have gone up to 45 without any problem. I came out nicely. So the most important, you have to maintain the 1:1 balance.
Yes.
You should not oversize the balloon.
Yes,
that is important.
1:1 means EL to EL diameter should not exceed.
Yeah, that's
luminal diameter, EL to EL diameter.
Yeah,
if it exceeds EL to EL means the chance of perforation is small.
Yeah, that's it. So Shreya, good care. Again, an applause to Anupam, and can we move to the next case presentation?
Sure, sir. Sure. Dr. Dixit, do the presentation.
Yeah. Right. Thank you. Thanks for giving me time. So I'll share my. Is it visible now?
Yes, it's visible.
So very good evening to all the esteemed panelists, and for the wonderful presentations. These are a lot more complex cases than what I'm going to present, but it's a wonderful learning experience. So I'll start with my presentation. So the patient is a 44-year-old male diabetic patient and a chronic smoker, and he had just been since last 1 or 2 days. And ECG showed the non-specific STT changes in 1 AVL, V5, V6. Cardiac enzymes are found to be raised, and echo showed regional wall motion abnormality in lateral wall with the ejection fraction of 45 to 50%. So a diagnosis of ACS sensitivity was made, and the angiography, we did the angiogram, and this was the condition of the vessels. So you can see the LED is LED has a CTO in the proximal segment, and there is a spontaneous dissection in the circumflex artery, which leads to TME1 flow in the OM2 branch. And the right side coronary, the RCA had 90% lesion in the proximal segment, and it is providing collaterals to both LED and the OM2. So yeah, so in this shot we also realized that there is a myocardial bridge in LED after the CTO segment. I hope it is appreciable here. There is a if it is visible, I don't know if you can make out, but there is a myocardial bridge over LED after the CTO segment. So we had a discussion with the patient. So he has got CAD TVD and with an LED CTO and dissection in proximal LCX and 90% lesion in RCA, which is giving collaterals to both the vessels. So we had a discussion with the patient, and he was advised to undergo a bypass surgery. But we involved this cardiac surgeon, and he said that he will not be able to do anything about the myocardial bridge, and grafting the vessel after the myocardial bridge may not give that much benefit to the patient. So surgical after the surgeon refused, or say he was reluctant to do the CABG. So we decided to take up the multi-vessel PCI, and with an idea to do address the LCX and the RCA lesion in the first stage, and LED CTO in the next stage. So I addressed the LCX lesion first, and after wiring and dilating. So this was the after stent deployment. The TME3 flow is restored in this vessel, and the result after addressing the LCX lesion, I went to the LED. So LED had a 90-degree bend, 90-degree angle with the left. There was a 90-degree angle bend between the left main artery and the LED, and there was mild calcification also. And the lesion, it had a blunt tip. The CTO had a blunt tip. So overall, the CTO score was GCTO score was 3, and the progress CTO score was also 3. So I tried to get a feel of the CTO so that I'll come prepared for the stage PTCA for the stage angioplasty. So I just to get a feel, I poked the vessel, and as it happened, I went ahead, and after parking my microcatheter at the tip of the at the proximal cap, I took a retrograde injection from the RCA, and I measured the distance that I have to cover. So it looked like the distance was less than 20 mm. So I decided to give it a shot and go ahead with the CTO in the same sitting. So after some time, I upgraded my wire from Fielder XT to Gaia 2, and after a while, I made some progress, and I realized that I've entered the diagonal. So I verified my position in orthogonal views. So it looked like I am in the true lumen. So I went ahead, wired it completely. Now, bridge is probably more visible in this shot. So I verified my position by passing a microcatheter and doing this maneuver, which made me confident that I'm in the true lumen and there was no obstruction. So I dilated the lesion. As I was in the diagonal branch, I was not able to get into the LED, so I dilated the lesion, and after that, I can see the antegrade flow in the LED. So now the antegrade flow is better in the LED, and After that, I took another wire and I entered the LED. And after that, things went well. So this was the final result of the LED. So this is now this was the end result after placing all the stents. So this was the result of the LED CTO. After that, I addressed the RC lesion as well. And after placing the stent, there was no more retrograde filling of either the LED or the OMSs. So I ended up addressing all the vessels in one go, which was actually not the plan, but I went, these things happened on the table, and I went ahead with the flow and addressed all the 3 vessels in the same sitting. So lesson learned from the case was that complete revascularization is possible, and it should maybe attempted in single sitting in resource poor countries and patient with financial constraints, provided we use the right approach and an advanced planning. Thank you, sir.
Now I can see Nikhil here.
Sorry, I missed the first part of the presentation. Sorry
Yeah,
for having to leave and come
That's
back.
all right, sir. Yes, sure, sir. I'll run it again.
No, it's okay. So I think you can take this one, and then Dr. Shubhanan, and then we'll and the other panelists, and then I'll again join you for the next case onwards.
This is again a very challenging case. Nice to see such cases being done with Elan, and but there is every good intervention needs a little bit of luck, because a true CTO LED, particularly at the ostium, where the angle is around 90 degree, if the filter X and with a blunt tip, it is very amazing for a filter XT to cross, and this is the luck where the luck laughed at the operator, because if that filter XT failed, it would have been a Pandora's box, because you could not penetrate that with a very stiff wire. It would definitely have gone to the sub-intimal space, and a lot of Pandora's box. So I think in such cases, yes, complete revascularization in such cases is very good. If you can do it, it is fine, but you need a little bit of luck. It is better to have a conservative approach. I would have gone for a LCX first, as you have thought of, then an RCA, then I would have come back, because if my CTO filter XT wire failed, then probably after some time I would have to try retrograde, because we had a very good retrograde collaterals.
Correct.
So unless you do a good thing to the RCA, your retrograde chances of retrograde would have been feeble. So this is this much, but that cannot drop out the applause which is due for you. It's a wonderful case again. Don't feel small that we have said a few words about it, but yes, it's a very good case. And I think Anupam will say something about it.
Yes. Actually, Dr. Dixit, you did a very excellent job in complete revascularization, and your approach of CTO is very, very apt. Why? Because not only your selection of this one, circumflex, LAD and RCA, and whenever a tapered proximal cap is there, remember that tapered tip will lead into the invisible microchannels. Remember, the microchannels can be visible sometimes or invisible. Once the cap is tapered, means your selection of the weight is apt. With a microcatheter support, first you documented the short CTO segment. So antegrade is your best strategy. Having had antegrade, the second step is taper tip. So the filter series is a microchannel tracking wires. Your search is apt. Having had a blunt cap, this one is, then the chance of microchannels are very less, and your selection should be Gaia series, directional wires. Remember, so apt with the microcatheter support, so invisible micro track, and only thing, because it lacks a composite core, it states it will follow and went into the branch rather than deflection into the LAD. Having had you selected the Gaia second which is intermittent load and a directional wire, you can directly go into the LED by means of its direction rather than to the branch because of its composite core racktone technology and intermittent load. Field XTS, invisible microchannel, it's selected and ultimately you modified and the second wire parallel wire you this one. Suppose Dr. Suvarna say, suppose if it goes into extra block, where it will happens in the blunt gap, then you can take the next high tip load as a parallel wire technique, Gaia, and you can enter into the LED very efficiently. Anyway, a nice demonstration of your complex case.
Sir, I have a question here. Sir, I don't know whether that question has come in everybody's mind.
Please, we have to ask question.
Just for my learning, nothing else. In this case, as Dr. Garg sir has very nicely shown the way the LED has opened and things like that.
Yeah.
Sir, if we notice, the stents have been placed across the myocardial bridge from top to bottom. So my question here is, if we don't have a landing prior to the myocardial bridge and the landing is after the bridge, so do we stent in such cases where actually like we know we shouldn't, but when we don't have an option in such cases, should we go across the bridge and stent it, or how to do it? Just a question, no pointing fingers at anything, just for my learning.
Actually, there's no data for regarding the bridge, but majority of case what you have seen, if you stop before the bridge, patient has angina with STT changes. You have seen, we have practical experience. Once you stent across the bridge, then the angina won't occur. So this is a practical one, but no data is there, to be frank. Sorry. Okay.
Anybody else on this?
No, I think that what Kapardhi sir has told, that in some cases we need to actually about that bridge also, with good antegrade injection, we would like to see the extent of the bridge, because retrograde filling with only
the bridge is quite significant actually. It is seen very well in the retrograde injection. It is quite
that is what after balloon angioplasty we should see with the antegrade injection what is the extent of the bridge, and it is good
if it is available.
So it is a good strategy to stent across the bridge in some selected cases. Only a question, as Suvarna sir has told, that as long as things go well according to plan, then everything is fine. But in CTO intervention and complex cases, we need to plan for our plan, not going according to our plan. So in some cases, I mean, what is the backup strategy and all? It is an excellent case, amazing case, and we are asking so many questions because everything went. I mean, sometimes it's difficult to believe how everything went so nicely.
I think fortune favors the brave.
As sir rightly mentioned, every case requires a bit of luck, sir. So
but then luck would come to the brave. It says fortune favors the brave.
Yeah, amazing case actually, amazing case, because the distal cap is in a bifurcation and both the vessels are large. So if we do any type of dissection or anything, then we are likely to lose one vessel. So that is another pointer towards a retrograde approach. I mean, the threshold for retrograde will be low for this type of distal cap where there is a bifurcation of two large vessels. Great case. Thank you, Dr. K.
Thank you.
Yeah. So I think the next case is Dr. Shetty. Is that right?
So Dr. Shetty is not here due to some emergency case.
Dr.
So
Jena?
we can go into it. So we have done Dr. Jena.
Okay, sorry, I missed that. Then who's next? Dr. Agarwal? Is
Saurabh. Yeah, Dr. Saurabh. He will be presenting.
Okay, Dr. Saurabh. So.
Yeah, am I audible? Hello?
Yes, sir.
Shreya, should I share the screen now?
Yes, sir, you can share the screen.
Please do that.
Yeah. Is the screen visible?
Yes, sir, it's visible.
Okay. Good evening, everyone. The chairperson, moderator, respected chairperson and moderator. After two very amazing, complex, heart rate raising cases, I would like to slow down a bit by presenting a relatively modest case which involved a calcific nodule, which I had to deal with an intravascular lithotripsy. So the case involves a 57-year-old hypertensive non-diabetic gentleman who had an episode of sudden severe chest pain a week prior to presenting in our outpatient department. He was treated at an outside hospital where he underwent angiography and was referred to us for revascularization. On presentation, patient complained of CCS class 3 angina and he had NYHA class 2 shortness of breath too. Now, on examination, he had stable hemodynamics. Cardiovascular examination was insignificant with no signs of heart failure. His echo revealed that there was a wall motion abnormality with ejection fraction of 45%. Now, we did a viability scan prior, which showed that the LCX territory on the viability scan was infarcted. Now, I'll show you the reason why we did the viability scan. So this was the angiogram which was done at an outside hospital, which showed a sort of a CTO kind of a thing at the LCX. So we just wanted to see whether the LCX needs anything to be done. But as it was infarcted, so we proceeded with the angioplasty to LAD, which showed roughly around 80 to 85% stenosis in the mid part. And there was visible angiographic calcification. So we were prepared for worse. We decided let's go ahead with imaging and then we can decide whether we need any intervention for that or not. So the baseline OCT run. So as you can see, the lumen was relatively decent. So we didn't need any prior modification of that calcium plaque, and we straight away went with the OCT. Now the OCT showed this is the distal landing zone, which is relatively fine. Then the calcification starts. Here there is a thick around 1 mm roughly calcium plate. Then this was a peculiar finding where where everyone can see, I suppose, there was a calcium nodule like structure. Then prior to that, there was another plate of calcium. Then this was where the plaque rupture kind of appearance was there in the proximal LAD, which shows a healed dissection. We tried our luck with the non-compliant balloon, and we went ahead with a 3x15 NC balloon. And as you can see at that particular part where the nodule was visible, the balloon was showing some waste. Now, post NC balloon dilatation, because there was some thrombus from the previous ACS event, there was some slow flow which got better with intracoronary nicorandil and sodium nitroprusside. Then we decided that we needed to shock the nodule so that the stent delivery is easier. So we went with a 3x12 mm shockwave balloon. As you can see, with each cycle of pulses, the balloon gradually opened up, and in the final image, the balloon had significantly opened up. So this is the OCT post IVL. Again, the proximal plate of calcium shows some cracks. Then this was the part where the nodule was, which seemed to have been sunken a bit. We went ahead with the stenting. We used the polymer-free PO-ISR because, again, I feel that the deliverability is a bit easier with the polymer-free and a low crossing profile of PO-ISR. So we post-dilated with the 3.5, at least in the proximal segment. This was the OCT after stenting. I'm extremely sorry for the poor quality because the lumen was not sufficiently cleared with the injection. But as you can see here, that stent is well apposed all through. So this was the final result. So this case I wanted to present because it had a range of OCT findings. This was the healed dissection from the previous event. Then there was plate calcium, which got cracked with the IVL, as you can see. There was some white thrombus also hanging around in the lumen. Then this was the nodule, which I felt was a non-eruptive nodule, which are more difficult to deal with as they don't crack very easily as opposed to the eruptive nodule. But as you can see with the IVL, the nodule at the same place, it had sunken. So The stent delivery was easier, and there was some fibrofatty plaque, and there was some lipid crystal. So range of OCT findings were there in this particular case, which led to a lot of teaching. So in conclusion, OCT can reveal multiple pathologies in an artery, and appreciation of morphology is important for better preparation and optimum stent expansion. IVL works in patients with a nodule, as evidence in our case, while producing cracks on either side of the summit of the nodule, resulting in collapse of the nodule as a whole and increase in the lumen area. Vivo ISR, due to its low crossing profile and polymer-free structure, can be delivered with a relative ease in calcified coronaries. Thank you.
Thank you, Dr. Saurabh. This is again a very good case, and particularly the calcium nodule and its effect and the effect of IVL on calcium nodule. It is so beautifully depicted that it is a memorable case. So I think Nikhil would have some comments on it.
Yeah, so I mean, taking it the nodule first, I think it's management of a nodule, and especially can be very, very difficult. And sometimes you can have no strategy which would manage a nodule. So that's a different thing. But only one comment I have is that once you've seen calcium, I mean, I would personally go ahead with deciding on the plaque modification and management of calcium before trying to manage it with a balloon dilatation. So, I mean, balloon dilatation as much as for placing an IVL, yes, if you decided on IVL, or if you decided on rotablation, then of course you don't need to pre-dilate at all. But the management of the calcium should be done before attempting it with the thing. I think you should decide, yes, I want to do it, I don't want to do it. I've never regretted managing, trying to take up a strategy for upfront for managing calcium, rather than later when I have one odd time regretted not using the device, whatever you want to do.
So I think it was the calcium burden was not too high, as you could see in the OCT. So we thought we'd take our chances with the NC balloon first. I completely agree with your.
When you landed up with kind of dilate with a balloon of this size, and you land up with kind of a dissection downstream, and especially if you from the shoulder of the calcific area, the junction between the shoulder and the other non-calcific. Sometimes you have severe dissections downstream when you dilate with a balloon of that size.
Dr. Saurabh, actually, you did demonstrated OCT-wise heterogeneous pathology, and the eruptive nodule is having a soft base compared to non-eruptive nodule.
Yes, sir.
Even it will yield for an NC balloon also, but as having a calcium, your strategy of IVL, especially acute setting, where the ectotomy devices are relatively not absolute, but relatively contraindicated. Your strategy is apt, and ultimately you got minimal luminal is optimal stent area. Actually, that is more important. To change the lumen rather than the wall, especially in the presence of calcium, with a very good minimum stent area, with a very good result actually. And OCT guided you like anything, because one side there is a healed this one, other side is the eruptive nodule which attract the thrombus, and your strategy, especially in acute setting ACS, not only the lesion modification but also the calcium modification with IVL is apt actually, with a very good minimal stent area for a long-term results. Nice.
Thank you, sir.
So can we go to the next speaker, if there is one?
Sir, Dr. Gaurav, sir, you can start your presentation.
Yeah, good evening. Good evening, respected senior colleagues. I'll just start my screen share. Can you see my screen?
Yes, sir.
Okay. Good evening. It is a very enlightening session, and I would just present a simple case of this 54-year-old hypertensive male who presented to me with CCS class 3 angina from almost 1 year. His baseline ECG and echo were normal, and coronary angiogram showed that the LMCA was normal, and LAD, as you can see, there is a long segment calcific diffuse 80 to 90% stenosis, and LCX has a proximal 80 to 90% stenosis, and RCA has a CTO with retrograde filling from the septal collaterals from the LAD. So we advise CABG to the patient, but the patient attendants were not willing for CABG at all, and because of this, even after multiple repeated counselings, since the patient was not willing, we thought that okay, we'll attempt a PTCA, and we thought that it would be rational approach that we attempt the PTCA to RCA CTO at the beginning. So so initially we engaged the RCA via the right radial approach. We engaged the RCA with the JR6 French guide, and I just took a run through wire for the first attempt, which obviously failed to cross. Then I tried to cross the lesion with the Fielder XT wire, and as you can see, the Fielder XT wire, after certain multiple talks and manipulations, it got stuck in some small branch within a calcific speck of the RCA, and the more and more I try to pull the wire, the guide is getting sucked into the RCA, but the wire is not yielding. And eventually, after multiple small attempts to pull the wire, the entire outer coil and coating of the Fielder XT wire was stripped, and the only part of the wire which was coming into the RCA was through the guide was the central core, which you can appreciate here. Now this Fielder XT looks like a regular run through wire, but it is not. It is actually the entire outer coil and the coating has stripped, and only the last 30 mm of the wire is still there inside the RCA. And the more and more I try to pull this wire, the inner central core is like a spring, and this was the first time for myself as well that I saw actually what is the true cross section, or what is actually inside the PTCA wire. When you feel it in your hands, it was like more of a indefinite spring, which is the more you pull, the more it gets elongated, and there is nothing yielding within the coronary. So now this was a catastrophe, and this was the first time that I had encountered such a scenario, and there is no stable anchor for me to support my guide, and because the entire coil and coating has stripped off, so I cannot mount any other hardware, even a simple balloon or a micro catheter over this wire. So now if I pull it more, I might lose the wire might get embolized and cause some thrombus inside the RCA or the aorta, which may lead to some sudden cardiac event in the patient. So first, initially what came through my mind was to just pass another run through wire across this RCA and then try to entangle the Fielder wire, but the more and more I tried, it failed. But while doing this, somehow because of this multiple manipulations, this run through wire crossed through this RCA CTO. As you can see in the next video, that the run through wire is very nicely parked into the distal RCA. We took a subsequent shoot, and there was no damage to the vessel, but the Fielder is still wire is still stuck inside that small branch of the RCA with the loss coating. What we did try next is that I passed a 2.5 into 8 mm balloon, semi-compliant balloon, over the successfully crossed run-through wire, and with the inflated balloon I tried to traction the entire assembly, so that with the support of the PTCA balloon and wire, the stuck Fielder XT wire can come out, but it failed. And while doing so, you can see here the coating got lost more and more, and only some last maybe less than 1 centimeter of this flimsy tip is remaining intact, and the rest of the wire is strip naked. So it is troubling me more and more, and while trying to traction this entire assembly, I lost the successfully crossed run through wire and balloon, and now the guide is also disengaged, and my wire is just hanging inside the RCA, and the wire is also almost there is no coating, there is no support. So what I do next is I again try to pass another run through wire after engaging the guide over this flimsy inner core of the Fielder XT wire. After successfully engaging, then again we were able to successfully cross this RCA with another run through wire, and then I deeply intubated the guide into the RCA, and then again tried this balloon traction maneuver with the inflated balloon, and this time I was able to successfully retrieve the entire assembly, and obviously the entire assembly had to be pulled out, and then we took some fluoro images to see whether if there is any possible remaining fragment inside the coronary or visible inside the aorta, which was not there. So but to my surprise, when I tried to reuse this same guide, we were having some difficulty passing the hardwares. Then only we realized that the entire coating of the wire is crumpled inside the guide, and then we changed the guide. We used another JR, and then we took a subsequent shoot where we can see that there is no dissection or perforation inside the RCA, and then subsequently it was like a regular PTCA because the run through wire had already previously crossed twice. So this time the run through wire had no difficulty, it crossed smoothly. Then we sequentially dilated the RCA from with a 2.58 semi-compliant balloon from proximal to distal RCA, and as you can see here, after pre-dilatation, this was the RCA, and then we took a 275 28 mm drug-eluting stent, which was Vivo ISR. We positioned and deployed it in the mid to distal RCA, and the subsequent shoot, as you can see, the stent is well expanded. Then we used a longer stent, that is a 336 DES, which is overlapped with the proximal stent, and we thought that so this should sufficiently cover the entire disease segment of the artery. And after inflation, we can see that the distal flow is good, there are no complications, but just immediately proximal to the proximal stent, we see some haziness inside the RCA, which was not there. So we thought that okay, this may be just concertina which might have happened, or this may be temporary. So we gave multiple rounds of nitroprusside and Nicoran and GTN, but this seemed to persist. But still I felt that okay, we'll go ahead with the post dilatation of both the stents, and then we'll see what happens. So we went ahead and post dilated both the stents with a 3.5 into 12 non-compliant balloon, and this was the shoot after the post dilatation. As you can see here, the haziness looks more and more bad. It has worsened, and it definitely looks like some form of edge dissection. So I thought it is better now to cover this with another drug-eluting stent, and we had to use another 3.5 into 18 mm Vivo ISR overlapping with the proximal RCA stent. And after this final stenting, these were the results, and these were my final results, where there was the distal flow was TIMI-3, there were no complications, and it was a smooth procedure. So coming to the discussion, the guide wire entrapment incidence is almost 0.1 to 0.2% of all PCIs. Risk factors include excessive rotation, manipulation, multiple reused wires, and particularly in calcific and tortuous lesions. Obviously, it can cause thromboembolism, dissection, perforation. Usually the methods, to extract the entrapped guide wire include the double or triple wire technique, which I was trying to use initially. Then we have this deep wedging of guide catheter and tractioning of the entire system, which worked in my case after multiple attempts, along with the support of inflated balloon. Then we have a snare loop technique and the microcatheter technique. But in my case, the challenging part was not the removing the stuck wire. It was the fact that I had lost the outer coil and the coating of the wire, and it was very difficult to maneuver the entire assembly and the guide catheter over this flimsy inner core of the central core of the wire. So there was no stable anchor to mount any other hardware, and there was a fear or fracture of the central core. So fortunately we were able to retrieve the wire. So these are rare complications, and we should always avoid use of reused wire, particularly in such high risk cases, CTO or calcific cases. We should ideally, these cases should have intravascular imaging, but as this was one of our scheme patients, we did not have that liberty. And as we all know, I think technicians are very important in our cath labs, and we should always, listen to them and trust their instincts whenever possible. Thank you.
Dr. Agarwal, it's a very nice and interesting case. What do you think? Why your wire broke? Is it only due to reuse or something, or there was something which could not have been done or could be avoided?
Sir, I think definitely I had panicked, because this was one of the first instances where I had come across such complication. So I think definitely I had panicked, and in that panic I felt that okay, if I pull the wire, then it might come out. But even after the first or second attempt of pulling, during my panic state, I think that is where, and this is what caused the loss of the coating of the wire.
So can I add some simple thing in that?
Yes.
Basically, this is a wire which is grouped as sliders.
Right, sir.
The filter XT wire is a slider wire.
Right.
So it is meant for sliding. So it is a tapered coat to tip, tapered and hydrophilic. Now the point is, these wires, if you drill, the problem of this is when you do a CTO, knowingly or unknowingly you start drilling. Now once you drill with these wires, if they catch the a very stiff portion of the CTO where it is already stuck, then if you pull, the whole thing will come out. This happens, and I'm sorry to say this, but this happens, in the beginning. Right. When we started with these wires years back, and I had a similar problem because I was used to drill with the wires like Miracle, and when I got such type of wires, when I drilled, this happened. So what I did, exactly same thing. It is like a deja vu. So I thought that what I did, I just put a snare in it, but I could not catch hold of anything. The snare, when I am catching hold of one thing, the thing is getting broken. So what I did, I put the snare inside the artery and rotated the snare, so that the portion of the wire which was entangled inside with the snare, and I pulled the whole thing out. Similar thing happened with one of my junior colleague, and there I put a plain balloon, undeflated balloon, and rotated the balloon. Now the whole assembly of the broken wire was intervened over the balloon, and I pulled out with everything. This is another thing you can try. So, Nikhil, if you
Yeah,
can.
so I think well said. And I think what I would, I don't know what really managed to get the wire out, but I think what you said in your last line is be calm, be patient. And I think patience helped you, and patience and perseverance. I think that is very admirable. And you could get yourself out of that complication.
Yes.
And of course, Dr. Subramanian has mentioned and most of our complications we've noticed, the bulk of our complications happen because of reused hardware.
That is
So,
true.
yeah, so wherever one has gone wrong, if it's a burst balloon or air embolism or anything, which I mean, by and large, has been reused hardware. So I think reused hardware, it may not be practical for everybody to use, New York hardware every time, but wherever possible, one should not try, especially with these, slider wires. I think it's not a great idea using used wires.
Yeah. Can I have comments?
Yes.
Anyway,
Please,
very nicely, patiently, you managed and bail out the complication, Dr. Gaurav. And most important, the lesson of the case is don't use Oxford polymeric jacket wires. This is a fundamental thing. Whether the polymeric jacket wires like Fielder series or Whisper or Pilot, all these are polymeric jacket wires, basically hydrophilic polymeric jacket wires. And second important is most important in Fielder, as Dr. Sonde aptly told, when you want to drill, and what happened is it went into hard portion and went into side branch, where very, very rare for new wires, because basically they are very sliding wires. Basically, because of polymer jacket, the least resistance and least feedback, tactile feedback you will get with these wires. So once it was caught in the hard portion and angled side branch, then because of its Oxford nature, some areas the coating will be lost, and some areas the coating will be there in Oxford wires. So where the coating is lost, it may sometimes stuck, and there you once because of panic state you pull back, and the coating will be lost. So of course, as a twisting wire technique, balloon twisting technique, another important is because the core is elongated, you can put the micro catheter till the tip. That's another thing, so that you can have a good support will be there to remove the stuck wire. Because it is already stuck and core is elongated, you can put the micro catheter actually over that one, because elongated and almost micro catheter length. Anyway, you very nicely, aptly managed, and don't use Oxford polymeric jacket wires. That is the lesson of the story. Thank you.
Yes.
Shreya, is there anybody else?
The last presentation.
Okay. So, if it is the last presentation, we should sum up by saying that it is a wonderful experience of having so many beautiful cases to be presented here. And the lesson is that particularly in calcium management, that calcium management is now is based on an algorithm. And not only it starts with an image or a coronary angiography, it also starts from the CT angiography and a mindset, so so that you can go step by step. And there is no one device which is which is not complementary to others, and no one device is enough for a calcium management. So you have to have an algorithm basis on depending on which you can treat the calcium nicely. So you need a lot of devices, maybe a ablative device, maybe a IVL, maybe OPN balloon. So all of them are in a complementary fashion in the management of calcium. This is number one. Number two is the without polymer jacketed wires, stents like Vivo ISR. This is a wonderful addition, because as there is no polymer, probably the DAPT duration is much shortened, and which is the most important point about the stents, and particularly nowadays we do a lot of, as for example, the Anupam Jena's case, the patient has a cerebral mass, and the DAPT in a long term would have been, disastrous. If the patient needs a surgery, then you have to stop everything. So in such cases, perhaps a non-polymer jacketed world is welcome. And number 3 is what Nikhil has said, and also Dr. Kapardhi said, everybody of us, that in our poor country, we reuse a lot of things, but these invite problems. When you use a reused thing, there is a chance of complications, and in such cases, you have to be very cautious to use a reused thing. With that, I think we can call it a day. And if Nikhil can add something, thank you very much for every presenter, and to Translumina for arranging a beautiful meeting.
I think you summed up the gist of the whole presentation very well. And I only would like to say is that, the calcium must be respected, and you must decide on your strategy to manage the calcium beforehand rather than as a bailout procedure.
Thank you very much.
Thank you.
Thank you, Dr. Kapardhi.
Thank you everyone for taking out the time and such wonderful benefits and what we can do, how to manage complex PCI. Thank you so much, sir.
Thank you.
Thank you very much.
Good.